So thank you for this opportunity to speak today. My name is Mike Braun. I'm a consultant medical oncologist at the Christie Hospital. So we'll now move on to the second part of the discussion about the impacts of genomic testing. So this is now really focusing on the impacts of genomic testing with systemic treatment. The main areas I've highlighted here. So there's germline testing, which currently is limited to looking at a specific gene called DPYD, and I'll go into the implications of that over the next few slides. And then testing for sporadic abnormalities, so abnormalities which have just occurred within the tumour cells. And the key ones to know about really are RAS mutations and BRAF mutations, which again, I'll go through on some of the following slides. So what is DPD? So DPD is an enzyme which clears from the body a drug called 5-FU, and 5-FU is the most commonly prescribed chemotherapy for colorectal cancer, and it pretty much would be given to all patients with bowel cancer who need chemotherapy, either in post-operative or pre-operative situation, or as controlling chemotherapy for patients with advanced disease. This protein DPD is coded for by an enzyme called DPYD, so the terminology can be slightly confusing. What the figure on the slide is trying to demonstrate is that of 5-FU which is given to patients, around about 80% is eliminated from the body by the DPD enzyme without having any anti-cancer effects. And this is a very rapid process, and we'd expect that the 5-FU drug, when it's given as an infusion, will only stick around in the body for about an hour before it's all removed. And then there's approximately 20% of the 5-FU which goes on through a number of different steps to be converted into drugs which can have an effect on the cancer cells. What we see with patients with an abnormality in this DPYD gene is that it results in a DPD protein which is less effective or completely ineffective at removing the 5-FU chemotherapy from the body. And this can result in a higher proportion or all of the administered 5-FU being converted into drugs that can cause anti-cancer effects, and that can then result in very severe toxicity from a patient's viewpoint. This schematic is trying to demonstrate that further. So the normal gene with 5-FU being cleared and tolerable toxicity, and then patients with deficiency where a very high proportion of 5-FU is converted into anti-cancer drugs, and the patient can have severe toxicity. Our data from assessing patients at the Christie shows that approximately 7% of patients in Greater Manchester have one mutation in the two genes, so are heterozygous for DPYD. And then approximately one patient in every 4,000 to 5,000 will have two defective copies. These patients are expected to have no functioning DPD activity. So it's these patients that we're trying to identify by screening patients for DPYD mutations, so that we can try and tailor the dose of chemotherapy appropriately and reduce the risk of severe toxicity. So there was a statement by NHS England in November 2020 requiring all patients to have DPYD testing prior to commencing treatment with 5-FU or 5-fluorouracil, as it's also called, or a drug which is converted into the body, into 5-FU called capecitabine. And there are four gene variants, so mutations which have been significantly associated with severe side effects from these drugs, and they're listed below. This is an example of one of the reports that we receive. So you can see with this report it says that there's no reduced functional variant detected, and it shows that the 4 variants recommended by NHS England have been assessed, and it comments that a standard dosing strategy can be used, so the clinician can use the normal doses which are recommended for these drugs. Our second example is a patient where it's been identified that they do have a variant in the DPYD gene, and you can see that then that variant is described, and there's a statement in bold describing that the patient would be expected to have a decreased functioning variant and would be an intermediate metabolizer, so they won't have lost all of their ability to clear the 5-FU drug, but it will be impaired. And then at the bottom you can see that there are some recommendations to reduce the dose of treatment so that the patient would be more likely to tolerate treatment, or an alternative chemotherapy can be considered if that is clinically appropriate. So as this is a germline test, the status won't change, so it only needs testing on one occasion prior to having 5-FU or capecitabine treatment commenced. The variants described predict a significant proportion of the patients who would go on to develop severe toxicity quickly after commencing treatment, but not all patients. And so when counselling patients, we have to be careful that we describe that it's trying to identify patients at higher risk, but does a negative result showing no mutations unfortunately doesn't exclude the chance of severe side effects. Most of the data that has demonstrated the importance of DPYD testing comes from Caucasian populations, and one of the areas of research is to do more assessments in non-Caucasian populations to see which genes are relevant in those populations. So we have to remember this when we're seeing non-Caucasian patients, just in terms of potential limitations of the testing. So then thinking about the sporadic changes, as I've mentioned, the most important are mutations in genes called RAS. There's 2 specific genes that we look at. There's KRAS and NRAS, and also a gene called BRAF. The figure here shows a cancer cell with a surface receptor, and then you can see that there's a pathway, and at the top of this pathway is the RAS gene, and then the second one down is the RAF or BRAF gene. So these genes and proteins are in the same pathway, and activation of this pathway is associated with cell growth, proliferation of cells, and survival of cells. So it's advantageous for tumours for this pathway to get activated. Mutations in these genes can result in higher proportion of tumours growing and surviving. In colorectal cancer, we see approximately half of patients will have mutations in either the KRAS or the NRAS gene, and approximately 10% of patients will have mutations in the BRAF gene. The most common and important mutation in the BRAF gene is this specific mutation called BRAF V600E. This currently would be considered one of the mutations associated with a very poor prognosis for bowel cancer patients in the advanced disease setting. In terms of clinical features, we see there is an association with mismatch repair deficiency. So approximately a third of these patients have MMR deficiency, and we'll come back to discuss that again in a few slides. It's much more common in the right colon than the left colon or rectum. And there's an increased incidence of peritoneal metastases and a slightly increased incidence in females compared with males, comparing patients who have mutation, this specific mutation versus no mutation. As mentioned, this is generally a poor prognosis group, unfortunately, with a survival from diagnosis of 10 to 14 months in most studies. And the kind of real feature of these patients is unfortunately that they progress very quickly on treatment, but then also after failure of initial treatment. This trial is the Beacon trial, which was an international study and looked to compare standard chemotherapy with two different options of treatment which do not contain chemotherapy drugs. So these are combinations of targeted agents aiming to see if this BRAF mutation, which is activating this important pathway in colorectal cancer, can be turned off in the cancer cells, and whether that approach of using a combination of targeted treatments may be better than our standard chemotherapy. This is the overall survival curve of the study. The trial was performed in patients who had failed at least 2 or 3 different chemotherapies. The grey line is patients receiving standard chemotherapy, and the red and the blue lines are patients receiving either 2 or 3 drug targeted treatments. And you can see that there was no real difference between those two approaches, but both of those targeted treatment approaches were significantly better than our standard chemotherapy, with patients living more than 3 months with these new treatment options compared with standard chemotherapy. As mentioned, there is a higher proportion of BRAF V600 mutations in patients with MMR deficiency, and those of you aware of the pathways for MMR and Lynch screening will know that BRAF mutation testing is one of the tests which is performed in patients who MLH1 or PMS2 loss, because generally BRAF mutation, if it's present, would mean that the patient is unlikely to have Lynch syndrome, and it's much more likely that they have a sporadic loss of MMR expression. In terms of RAS mutations, as I've said, we check for mutations in 2 different genes, and compared with BRAF, where it's really one mutation we're interested in, KRAS and NRAS testing covers 11 different mutations across those genes currently. This figure, or this table, shows data from the 2 key trials using targeted agents combined with chemotherapy versus chemotherapy alone, and in patients who had no mutations in these genes, so patients described as being wild type. In both these studies, there was an 8-month improvement in survival if patients had the additional targeted agent compared with having chemotherapy alone, so substantial improvements in life expectancy. And this is the real reason why we look to ensure that this testing is performed and patients have the option of going on to receive this more effective treatment. So in terms of assessing for mutations in the UK, as I've described, if patients have no mutations or a wild type, they can have a combination of chemotherapy with a specific EGFR targeted drug. So there's two of these drugs, cetuximab and panitumumab. And patients can only in the UK access those drugs in the first line treatment setting. In terms of patients who have mutations, these patients would typically go forward with standard chemotherapy alone. RAS mutations, as compared with the BRAF gene, have proved more difficult to try and develop drugs that would target these mutations. And as described, there are multiple different mutations which appear to be important. Nevertheless, some recent trials have shown potential benefits for drugs which specifically inhibit the specific RAS mutations, and it's likely that some of these drugs will come into clinical use over the next few years. One of the final abnormalities to mention is a rare abnormality, which are fusions of the NTRK genes, and these are really quite rare in colorectal cancer. But this is an interesting area as a drug is specifically available and approved by NICE across all tumor types if these NTRK fusion identified. Despite testing multiple patients in the Northwest, unfortunately we've so far not identified any patients who are suitable for this specific therapy. We do see from the clinical data which is now becoming available that there's a higher proportion of these tumours which are MMR deficient, and these mutations also don't tend to occur if a patient has RAS or BRAF mutations present. So we're increasingly able to focus testing on patients without RAS and BRAF mutations, and particularly patients with MMR deficiency, where it may be that we're much more likely to see these mutations. So in conclusion, hopefully I've demonstrated to you that genomic testing plays a key role now in the management of patients with colorectal cancer, and certainly anybody having chemotherapy will have some form of genomic testing performed, with DPYD testing, and for patients with advanced disease, testing of RAS and BRAF mutations, which are key in terms of determining patients' treatment options. New tests are being added periodically. So again, this is not a situation where there is a fixed testing panel that is not likely to change. We are seeing changes with new targets and new indications being added every few years. So it's an important area to keep abreast of. Thank you very much.